Welcome everyone to the Cancer Immunotherapy in You patient webinar series brought to you by the Cancer Research Institute. Today is Tuesday, August 29th, 2017, and the topic for today's webinar is biomarkers in immunotherapy. How much do they matter? This webinar is being recorded and will be made available on the Cancer Research Institute website and on our YouTube channel. Before we begin, I'd like to thank our generous sponsors who make today's webinar possible. That includes Bristol Myers Squibb, Genentech, Regeneron, and Advaxis Immunotherapies. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute, a nonprofit organization dedicated to saving more lives by funding research that aims to harness the immune system's power to conquer all cancers. This work has contributed to the development of life-saving immunotherapies for a variety of cancer types. We present this webinar series to patients and caregivers to help them understand what immunotherapy is and how it differs from other treatments, as well as to provide information on the latest developments in research and treatment, and to connect patients to immunotherapy clinical trials. I'd also like to mention that if you're interested in learning about cancer immunotherapy from experts or connecting with other cancer patients and caregivers, the Cancer Research Institute is hosting an Immunotherapy Patient Summit series in 5 cities across the United States, with upcoming Saturday summits happening in New York City, Houston, and Tampa. It's free to attend, and we encourage you to register today at cancerresearch.org/summit. There will also be a live streaming option available on September 23rd for those of you who are unable to attend the summit in person. Now it's my pleasure to introduce today's expert speaker. Dr. Haidong Dong is an associate professor of immunology and an associate research consultant in both the urology and immunology departments at Mayo Clinic. Dr. Dong's research focuses on defining the regulatory mechanisms that influence tumor immune cell interactions and anti-tumor immunity, as well as understanding how tumors become resistant to immune responses. His lab's long-term goal is to translate these basic research insights into effective cancer immunotherapies. And with that, Dr. Dong, welcome.
Thank you. Thank you for this opportunity to share our research and what they are meaning for our cancer patients. And first, I would like to introduce the concept of biomarkers. So what is a biomarker? Biomarker is a substance that can be reproducibly measured and reflects a normal condition or a disease process in the patient. We need a marker because we cannot see with our eyes to see what's going on in our patients. So we need some method to measure them, monitor them, and then to learn what's the consequence of these changes in these biomarkers. So biomarkers can include a variety of signals. That could be T cell, like immune cell activity, function, like a proliferation. Also, we can look at tumor mutations because tumor cells keep changing their genomic informations. That can give us very important insight for what the outlook of a typical cancer will be. Also, we can learn from the biomarker tell us what the stroma cells, the cells surrounding the tumor, the supportive tumors, what they behave. And also we can look at the details of molecule pathways, like metabolism, biochemistry reactions, molecule-molecule interaction in the cells, especially in the cancer cells or in the immune cells. Also, we can measure some protein levels in our blood and to see how this protein change will tell us the conditions inside the cancer patients. So basically, biomarkers can be applicable to all the cancers. So we need them to learn more and to identify the therapeutic targets, also to help the cancer patient to survive. So why we need the biomarkers? there are several clinical benefits of biomarkers. For example, and the biomarkers can tell us what type of cancer we have. It's like a diagnostic. Like a HER2 can tell us it's a breast cancer. PSA can tell us, oh, we may have prostate cancer. And also, biomarker can tell what's the consequence of the long-term outlook of our disease. And I will introduce more about this based on the tumor biomarker PD-L1 in the next slides. So this biomarker is crucial because this will determine how frequently or how intensively we will treat a cancer based on the prognostic. And recently, the cancer immunotherapy become another very promising therapy for later stage cancers. So, but not all the patients respond well to this therapy. So we need to know why some patients work and respond well to the immunotherapy, but some they don't. So these predictive markers can tell us maybe before the treatment or on the treatment, so we know how this patient will respond to immunotherapy. And on the other hand, we want to know, because immunotherapy is a long-term therapy, and we want to know at a certain stage whether this therapy works in a patient or not. So the biomarker can tell to what degree this treatment, the treatment will change the immune response to the patient's cancer. And also, we know immunotherapy, they have some toxicities. They call it immune-related adverse effects. Some will be very serious. So we have to prevent them as possible as we can. Also, we have to prevent them beforehand. So we need some markers to tell us what's going on and what's the chance of the toxicity what happens. And in the long term, we want to know, especially after the surgery, radiation, traditional therapy, and even the immunotherapy, we want to know what's the consequence, how long our cancer will be treated, and how, to what degree it will progress, and when it can come back or they spread out to the other part of our bodies. So take together, biomarkers are very important. It gives us a lot of insight information about our disease progressions, about the response to the current therapies. Here is an example about the immunoprofile in their response to immunotherapy. So a couple years ago, people developed so-called immune score. That means they used the tissue staining method to identify the presence of T cells. T cells is a type of immune cells in our body. They can moving around in our blood. Also, they can come to the tissues. For example, here is a CD8, is one type of the T cells. This type of T cell, they have the ability to kill the cancer cells directly once they are activated, when they know they are right target. So these T cells are very important to protect us from cancer cells, and their presence in the cancer can predict how this patient will respond to immunotherapy as well as to their survivorship. So if you have more CD T cells in tumor tissue, the outlook is better than if you have fewer CD T cells inside the tumor tissues. So here you can see the green cells, they are CD T cells. They are infiltrating the tumors in the background. Here you can see a lot of CD T cells. They come together, form a boundary, and they are surrounding the tumors and kill them. So this immune score is very useful in predict patient response and their survival, especially in some cancers like colon cancers. So besides the CD T cell infiltration, we know these cells, they can come to the tumor to kill them, but most of the time they don't work well. They need help. So the reason because the tumor cell develop their own immune resistant system. We call it immune checkpoint molecules. Tumor cells use immune checkpoint. Here is an example. They call B7H1 or PD-L1 because it binds to his receptor called PD-1 on the T cells. This interaction gives signals turn off the T cells. So once the T cell get closer to the tumor, they are activated by the tumor antigen, and they are ready to do their job. However, at the same time, the signal from immune checkpoint PD-L1 and they turn them off. Like a car, you start the engine, but you cannot move because some people apply the brake. So even you have T cell inside tumor, sometimes the T cell couldn't work to kill the tumor cells. So recently, a new therapy called immune checkpoint blockade therapy. It functions to block the interaction between the PD-1 and the PD-L1. And then the T cell cannot be surprised by these immune checkpoint signals, and they are restored to have their effector function to kill the tumor cells. So that's the novel therapy, so-called immunocheckpoint blockade therapy. Because the PD-L1 expressed by the human cancers, and its function is to suppress T cell response to cancers. So B7H1 or PD-L1 can be used as a biomarker expressed by cancer cell, can tell us what's the outcome, the prognostic, as a prognostic factor to tell us whether a tumor with or without PD-L1 expression, they have impact in the lifespan of cancer patients. Here is an example. You have the cancer cells, the kidney cancer, for example, and then they express a high level B7H1. They cannot survive longer than the patient with their tumor. They don't express B7H1. So the survival curve is huge difference. So the 5-year, for example, here, the 5-year survivorship in a patient with positive tumor B7H1 is about 45 percentile. But if their tumor are negative for B7H1, the 5-year survivorship increased to 90, close to 90%. So measuring the B7H1 expression in tumor tissue can predict how long this patient's survivorship will be influenced by these immunocheckpoint molecules. Besides the tumor tissue, we recently developed a predictive marker in the patient's peripheral blood. A protein called PD-L1, soluble PD-L1. It's different from the tumor tissue PD-L1 because they can be secreted from tumor tissues and they are circulating in our body, especially in the plasma. We can easily identify them. So these protein levels in the patient, here I give you example in melanoma patients, before the immunotherapy, and the soluble PD-L1 level increased dramatically in this population of patients. This population, actually, they don't respond to immunotherapy. Compared to the patient respond to the immunotherapy after 12 weeks of treatment. Interestingly, and some of these patients, if they have a higher level of soluble PD-L1, they have the increased chance to have the immune-related adverse effect. So the increased level of soluble PD-L1 can predict two things. One, their resistance to immunotherapy. Another one may predict their sensitivity to the immune-related toxicities. So this is a very important marker identified in the patient's blood that can be used in the future study or clinic trial to identify whether it is a valuable biomarker for our patient management, especially when they are going to receive immunotherapy, like anti-PD-1 immunotherapy. Okay, so besides the tumor tissue, we measure the PD-L1 expression by tumor cells and the protein PD-L1 in the blood, and to monitoring patient response. We also identify a molecule called the BIM in the patient's T cells. So BIM is a molecule, normally it functions to promote T cell death after T cell activation, after T cell finish their job, and it's like a self-control molecules. And interestingly, also unexpectedly, we found out higher beam expression in the T cells, especially in the T cells in the peripheral blood. They can identify highly effective T cells in the patient. So these highly effective T cells, when they move into the tumor tissues, they can recognize tumor cells, and then they can kill the tumor. However, because they have a high level of BIM, we know that BIM promote or prepare T cell to die. If this signal is not turned off right away, they will be killed by the PD-1, PD-L1 interaction, because BIM, we found, is a downstream signal of PD-1. So in this situation, if you give the therapeutic antibody, either anti-PD-1 or anti-PD-L1 antibody, this signal can be blocked, and then we can rescue the T cells. They are highly effective T cells, although they are sensitive to T cell death signal by PD-L1 or PD-1 because they have higher level of BIM. But our antibody can block these signals and protect these cells to die, and then let these immune cells to kill tumors. So that's exactly what will happen in our patients. They are responding to immunotherapy. However, if the patients, they have less effective T cells, we can learn that from their lower expression of BIM in their peripheral blood, because these patients have fewer effective T cells, even they come to the tumor tissues. They cannot compete with overwhelming tumor cells. Even we give them antibody, we can only rescue a very few of them, and then this disease cannot be controlled. So this is patients, and they will have their disease progression. So based on the BIM expression, we can distinguish at least two populations of T cells. One is highly effective T cells, another one is less effective T cells. And measurement of these T cell BIM levels can predict how patient responds. As here is the case in the clinic treatment of melanoma with anti-PD-1 therapy. So here is at the baseline, means before we give the anti-PD-1 therapy to patients. So we take the patient's blood, measure their T cells for their beam expression. You see here the responders, they have a higher level beam positive cells among their T cells, and in the progressors, they have lower levels. And in responders, you can see here, their tumors shrink after 12 weeks treatment. And very interestingly, in the responders, the beam level decreased dramatically. However, in the progressors, either they don't change much or they increased. So the dynamic change of the beam level from the baseline and after treatment can tell us whether their T cell respond to the anti-PD-1 therapy. If they have higher beam levels, and this patient most likely benefit from the treatment. However, if the patients they have lower level beam in their T cells, and the chance for them to respond to this therapy is very low. So measurement of the T cell beam level can predict patient response to anti-PD-1 checkpoint blockade immunotherapy. Another very interesting thing in the beam expression is beam expression can tell us honestly whether or not this patient have so-called pseudoprogressions. The pseudoprogression is a phenomenon that after a treatment, especially in immunotherapy, the tumor size seems like swelling or get worse. Basically, based on the CT scan here, you can see, oh, this cell's tumor tissue gets larger. So, and before treatment, here is melanoma in the spleen metastasis. So after treatment, you see here, seems the signal increased dramatically. And this usually indicate the disease get progression or get worse. However, after a while, if you continue to treat them, the tumor disappeared. The tumor size go down. So by the CT scan, this imaging may tell, oh, this patient didn't respond to immunotherapy, they are progression. However, and eventually this patient actually benefited from immunotherapy. So now we need a biomarker to tell us what's really happened at 12 weeks. Is it really they have disease progression or they are transiently have this progression because the enlarge of the lesions are not due to the tumor cells expansion. Here, as the figure show us, is because the T cell infiltration. We know the immunotherapy is to enhance the T cell expansion or accumulation at the tumor size. So this increased population of T cells, not tumor cells, may also contribute to the enlargement of the tumor tissues. So that's why they call it pseudoprogression, because not tumor progression, because is the T cell actually they are come to the tumor size. And we measured the beam levels at the 12 weeks. We found very dramatic decrease of beams, T cell populations in their peripheral blood. In contrast to this downregulation or decreased population of beam positive cells, in the real or true progression patients, and the beam level didn't change or increased. So based on the beam level, we can clearly separate who are true progressors or the patients they have pseudo progressions. And then if we continue to monitor this patient, and even after 36 weeks, their beam level is still very low in the responders. So although we don't know why the beam go down dramatically, in the peripheral blood, and then in their tumor tissue seems like more T cell infiltration in the tumor tissue. But we know from the mechanism like PD-1 blockade may help the T cell expansion in tumor tissue, or they retain them in the tumor tissues. So that's why, and the T cell, they have a lower beam level in their peripheral blood, and this T cell may end up in the tumor tissue to reject the tumors. So the future change for the immune-related biomarker is we know only one biomarker may tell only one side of the whole story. And for example, the PD-L1 expression by tumor tell us what's going on in the tumor cells. And the soluble PD-L1 may tell us how the tumor cells hiding in another side of the body, what they are doing. And beam tell us what's going on in the T cells. So I think in the future, we need to combine these different biomarker and integrate all this information together, give a more clear, complete picture about the process of the disease, and then how they respond to the immunotherapy. And in cancer patients, because the cancer in the contact with immune cells, besides the T cells here we mentioned and tumor cells, there are other cells also contribute greatly to the cancer immunology and immunotherapy. For example, the dendritic cells and antigen-presenting cells, they also determine the very early stage of T cell activation. They present very specific antigen to T cells. So we need some biomarkers to identify their functions. And also we know immunocheckpoint play a role in limiting the T cell response to cancer. But other cells, like regulatory T cells, macrophage, or MDSC, these immunosuppressor cells, they also contribute to have tumor cells escape immune attack. So in this scenario, we need markers to monitor the function, the frequency of other immunoregulatory T cells and macrophages inside tumor tissues. And it's still, we don't know why some patients, they don't respond to immunotherapy. That could be some reasons intrinsic in the tumor cells, or could be something happens in the immune system. So we need more approaches to identify new biomarkers. For example, recently people identified neoantigens in tumor tissue. So that could predict the response to immunotherapy. But we don't know how many neoantigens we need to maintain a durable immune response, and whether or not these antigens can be used as a vaccine to enhance the immune response. And another most important thing is the immune-related adverse effect. We need a reliable markers to for the safety of this treatment in the clinic practice, and also we need more or less invasive biopsy for the tissue studies. And because the limited resource for the biopsy, we need more very sensitive and specific tools to study the tumor marker and their immune profile, especially when they respond or don't respond to immunotherapies. So the future of the biomarker field will be combined biomarkers, provide the rationale combined therapy to target different stage of cancer and different type of cancer, and to increase the efficacy of immunotherapy. Also, our goal is to promote the survivalship of our cancer patients. Thank you very much, and I'm happy to have questions.
Well, thanks very much for that, Dr. Dong. You know, biomarkers are a hot topic in the media. Some of the recent FDA approvals of immunotherapy have included biomarker um, as a criterion. So I guess before I get into the questions, I only would like you to explain something to me that I think I was a little confused on. So you mentioned that higher levels of the BIM biomarker corresponded to more effective T cells. But then in your chart on pseudoprogression, you said those BIM expressing T cells decrease, um, even though the patient's responding. But then you mentioned peripheral blood. So is it only decreases in the periphery, and the reason that the levels are lower is because those T cells are in the tumor fighting the tumor?
It's a very interesting question, yes. And I try to clarify on the two parts of this whole picture of the T cell beam expression. So usually the beam level increase in the effector cells. So effector cells, they have more effector molecules, they are activated, they are ready to kill tumors. And so before treatment, the increased level of BIM tell you these patients, they have more effector T cells. It makes sense because, based on the immune score information, we need more effector T cell to kill cancers. Okay, interestingly, why these T cells, effector T cell, they decrease in the peripheral blood after treatment, and it seems like these treatments work because their tumor is shrinking. So we don't know exactly what's going on, but we can explain this scenario based on the migration of this beam positive T cells. And because they are effector cells, and they usually cannot stay longer inside the tumor because the tumor expresses high level PD-L1. So the PD-L1 and the PD-1 interaction will further increase the beam levels and kill them by apoptosis. And if the PD-1 blockade works, you can accumulate more and more T cell inside tumor and kill them. So because the activation or the protection from PD-1 blockade, you have more T cell be maintained in the tumor tissues, and then accordingly, this type of T cell will decrease in the peripheral blood because they are retained inside tumors.
Mm-hmm. Well, that makes a lot of sense. Do you ever see that BIM expression levels will become a criterion for whether or not a patient should receive immunotherapy?
We don't have the immunotherapy data yet, but however, we have unpublished data we found in a cancer patient. If the beam levels expressed by the lymphocytes, if this beam positive lymphocytes increase in the tumor tissue, they predict better survivals. So this indirectly, support our hypothesis that if the PD-1 blockade can help these cells stay inside tumors, they can do their job because they are effector cells.
Okay.
I think the future study will definitely we need to validate this hypothesis and get biopsy from the patients respond to the tumor.
Yeah. It looked like some of the patients with low levels of BIM still responded. I mean, they're less likely to respond, but it doesn't seem that it's necessarily a signal that you're not going to respond. In fact, take PD-L1 expression. You see that some patients who don't express still respond to immunotherapy. Can you explain why that is?
I think one simple answer is because either PD-L1 by tumor or beam by T cell, they are dynamic because we only can do the monitoring and measurement at a single time point, but there are levels changing according to the context, the signal they receive. For example, PD-L1 expression by tumor was discovered as a mechanism, so-called adaptive resistance, based on what the information they get in the tumor tissues. And similarly, for the T cell beam expression, we know a PD-1, PD-L1 interaction is just one mechanism contribute to beam upregulations. And also beam level may be regulated by other signals. So it also, especially in one tumor patient, and they may have the different or very unique, we call it internal immune environments, and their levels will be determined by the not only PD-1 or PD-L1, could be by other immune checkpoint molecules, either positive or negatively regulated. Yeah.
So it's just part of the puzzle, and there are a lot of other pieces at play, and that could explain why some patients. I only ask because as a patient is talking with his or her oncologist about this, and the subject of biomarkers comes up, I think it's important that the physicians let the patient know, that some do respond and some don't. The fact whether they have it or not doesn't necessarily predict. It does, however, give an indication that there might be a certain anticipated response. Kind of coming back on a simpler level, if you have two patients, they both have, let's say, kidney cancer. How is it that one patient's kidney tumors may express high levels of PD-L1, or their T cells may be BIM positive, versus this other patient with the same exact type of cancer, but they've got a completely different profile when it comes to the presence of biomarkers? How do we explain that?
It's a very interesting question. Yeah, I think, if we have two patients, they have a different profile based on their tumor PD-L1 expression and their T cell beam expression. And based on the current knowledge, we may tell the patient, the chance for you to respond to the, for example, PD-1 immunotherapy is a higher or lower. But this information should be carefully used in make a clinical decision, because it's informative but not decisive. So that means the oncologists have used this information to closely monitor their patients. Some patients, their levels may be in the middle. Most of them could be like that. So, and because I said these markers are dynamic, so maybe that what's just one time point may not tell you the whole story. So we suggest some ongoing or on-treatment monitoring use these markers. For example, the T cell beam in some patients, it didn't change much, meaning in the responders, it didn't decrease dramatically, like 6 weeks after treatment. Some you may need weeks, 12 weeks, or some 30 weeks. So because the response to immunotherapy varies dramatically in different patients, also it takes a longer time. I would suggest to use this marker, and especially at the baseline, to predict what will happen, but most importantly, during the treatment process, to use these markers to monitor the patient response. And especially for the T cell beam, because you don't need tissue, you can draw a little bit of blood, like 1 ml is enough to measure them.
Are these standard tests? Does every patient who goes in to receive an immunotherapy get screened for these biomarkers?
Not right now, but right now is only in the early stage of research. So we expand this patient population. We did a second cohort validation study, and then the results are very promising, and tell us more information, what happens in these patients. And this predictive value and as a monitoring value also are significant. So, we are happy to know, and this marker can tell whether or not this therapy actually works. in the patient before the CT scan or the PET scan eventually can identify this patient respond to this therapy or not.
So as I mentioned, biomarkers are a hot topic, and part of that is a discussion around their real value in protecting or predicting how patients are going to respond to immunotherapy. We're about to wrap up here, but what's your final word on biomarkers? Where are we?
Biomarker discovery should be based on the mechanism, because the biomarker reflect or identify a process or condition. In the immunotherapy, because it's the interaction between tumor and the immune system, so the biomarker should reflect honestly, objectively, or dynamically see how this interaction will determine a clinic outcome. Thank you.
All right. Well, thank you so much for your time, Dr. Dong. Really appreciate you spending time with us today to talk about this very interesting subject. It's something that I think is going to come up more and more often as we learn more about biomarkers and as we discover more of them and their significance to cancer patient care. So in closing, I'd like to thank once again our generous sponsors, Bristol Myers Squibb, Genentech, Regeneron, and Advaxis Immunotherapies. Also to once again remind you that we have this patient summit, immunotherapy patient summit series, and the next 3 will be in New York, Houston, and Tampa. Registration is free, so we highly encourage you, if you're able to come, to register at cancerresearch.org/summit. Also, if you'd like to learn information about immunotherapy for many different types of cancer, you can come to cancerresearch.org to learn about this. The URL is wrong on this, unfortunately. It should be just cancerresearch.org/patients. And when you go there, you can browse up to 20 different categories of cancer to see what is the latest research that's going on, where are the clinical trials that are testing immunotherapies in those tumor types, and you can also learn about what the Cancer Research Institute has been doing to further immunotherapy progress in those types of cancer. Once again, this webinar has been recorded and will be made available on our website, which you can view this and all our past webinars at cancerresearch.org/webinars. Thank you again, Dr. Dong, and thank you all for watching today. Goodbye.
Thank you.